Okay, hi guys, my name's Ed. This is a professional Liverpool event that we've done in collaboration with, let me get the name right, Constructing Excellence Liverpool. And we got two guests with us today. We got Johnnie Garside, who's the Health and Wellbeing Manager at Everton and Community. We'll pass over to Johnnie first. And we've also got Vikki Thomas, who's from Seddon and the Relationship Manager there. And she'll come on second, do her part. And then finally, I'll do a little bit on COVID and mental health presentations that I've seen in and around hospital and GP surgeries. So without further ado, over to you, Johnnie.
Thanks, Ed. And morning, afternoon to everyone. Great to be with you and share with some of the things that Everton and the community have been leading on in this area of supporting mental health and well-being through what has been a very difficult kind of year. Or coming up to a year for a lot of people. So just going to start with a brief overview of who we are, Everton and the community, the work that we do, and then finally just kind of touching upon some of the work that we've been developing, as I say, in light of the COVID-19 pandemic. So Everton and the community, we are the official charity of Everton Football Club, and I do hasten to add we are financially independent. We are the charitable arm of the club in the Greater Merseyside region, and we develop and deliver a range of innovative support programs and engagement programs for some of the most hard to reach, vulnerable, at risk and marginalised groups within the city. Each year we'll approximately engage around 20,000 people, and that can be across the full life spectrum from young people right up to older people, and specific target audiences within that. My expertise in our department focuses on the health and wellbeing needs of those within our community, and our programs centre on what we call key transition points, or where the literature or our experience will tell us that a lot of health risks and factors are at play. So key transition points that you can think of: moving from primary school to secondary school for young people, moving from employment into retirement for people of a certain age, moving from the military to civilian life. These are what's called kind of big transition points in people's lives that people can experience, and our experience within operating in this field, and obviously research will tell us that there's a lot of risk factors associated with kind of key life changes or transitions. So our programs kind of sit within these spaces from kind of three different perspectives, really. One, and first and foremost, is prevention. If we can kind of support people to navigate these difficult life circumstances or transition points well, smoothly, robustly and resiliently, great. We also sit very much from an intervention point of view as well, you know, when problems are already in place or when somebody needs support, be that chronic, acute, or just mild to moderate, and then the ongoing support that then goes alongside that. So from kind of three agenda points: prevention, intervention, and support. We develop and deliver, as I say, a range of different programs, from targeted NHS provision work supporting those with underlying mental health conditions, to cancer rehabilitation and dementia and Alzheimer's support. And as I say, that's just a flavour of some of the work that we do, and just conscious of time, I won't go into all of the details, but I will put a footnote in the chat function and a link to our website for those who would want to inquire and do some more research around the work that we do. Moving gear slightly, I'll just kind of talk about some of the approaches and some of the work that we've been delivering kind of since March last year in light of the COVID-19 pandemic. I think it's safe to say that, you know, the pandemic has affected everyone from every walk of life, be that in relation to, you know, contracting the disease, through to experiencing bereavement to a loved one or someone close to them, be that in relation to employment and being placed on furlough, or in fact being made redundant. And as I say, all of the social aspects and loss of kind of social liberties that we take for granted. Everyone in every walk of life has been affected. So we moved quite quickly and swiftly in the kind of early days of when it was emerging, the pandemic. So in March last year, we coined our Blue Family campaign, which is a strategic and specific outreach and support program specifically tailored for those affected by the COVID-19 pandemic, which has been practical, supporting those who've been experiencing financial difficulty or hardship, be that in relation to fuel poverty, digital poverty, food poverty, and then also supporting those with well-being and health and mental health support needs. So it's been a really fascinating project that we've been involved with and developed over that time. And to date, we've supported over 27,000 people with various different support needs. And as I say, that's been an ongoing process that's grown and grown since March last year. And in partnership with that, we've got an online provision program that kind of goes alongside the practical support arm of the project, which has a whole host of support services and resources available for people to access to obviously support people's underlying mental health and well-being through what has been a very difficult time. As I say, I can put a footnote in the chat function for a link to those resources and that specific campaign. But also in an attempt to bridge the digital divide for those who experience digital poverty, we've also put a range of provision in place to support those who aren't able to access remote or online support services. So that's taking the form of postal services and activity packs and more easily accessible resources, obviously weekly check-in welfare calls, as well as a range of different activities with adherence to social distancing guidelines to ensure those who haven't been able to access online provision can still feel supported. So that's just kind of a whistle-stop tour really of Everton in the community, the level of work that we do specifically around health and well-being and the work that we've been developing since the outbreak of COVID-19. More than happy to obviously field any questions. And yeah, thanks for the invite.
Yeah, cheers, Johnny. Really good. I think we were discussing before the call. We'll just open up the floor now for 2 minutes if anyone has any questions to Johnny specifically, and then we'll do another round at the end. But if anyone wants to chirp up now and ask Johnny a question, feel free to put it in the chat or unmute yourself and also ask a question. So we'll just give it 2 minutes if anyone wants. I actually had a question, Johnny. We'll give people a chance. It was just around, you mentioned transition periods, people's lives and it being high risk. What kinds of things have you seen? Because, it's the research is clear around that. Especially the highest risk period that I've seen from the research I've read anyway is people going to university life. They move away from support networks and whole new friendships, new leaderships required, like within themselves. They have to be way more independent. There's so much change there that there's so many new risks. What kinds of things have you seen?
Well, it's different with each kind of transition point that people experience. It's not a one size fits all approach, and there's individual variance obviously with how people can kind of navigate any big transition point or life change. But what we tend to find is that as we are creatures of habit, when a certain type of habitual nature or routine or structure can be changed or differs, we can take a time to adapt to that. And, I think we can all attest to that in recent weeks and months with many of us kind of having to change our routine from, commuting to a workplace to working from home, from being able to do what we wanted to do when we wanted to do it with, social activities or meeting friends and family, and having to adapt to a new way of living, a new way of working, that it's taken some time. But underlying that is if people don't have those real kind of skill sets that emotional resilience, that self-awareness, that kind of way of kind of changing their perception or their habits or their lifestyle. It can be a slippery slope, and it can be hard to adjust because, like you say, we are creatures of comfort, creatures of habit. And when those are changed or altered to what we have become accustomed to, it can take a long time. And sometimes if our self-awareness isn't, in place, we can almost be oblivious to it, that there's changes taking place, or we're coping in a maybe an unhealthy way, or a way that's kind of counterintuitive to what we're trying to achieve. So we try and work with people to upskill them, basically. So on the job training, like you might say, or CPD training in a professional sense, it's no different than when it comes to our own health and well-being, that we should be all equipped with a health and well-being kit bag or a tool bag, or whatever you want to call it. If you're going to be prepared for something, then it takes time, it takes effort, it takes research, it takes a level of kind of skill and intellect to be able to do that. But these are the types of things that we aren't really taught. Where do we learn self-awareness? Where do we learn emotional resiliency, emotional intelligence? It's a difficult skill, I guess, to master. And I do stress the word skill. It can be learned, but it's just, as I say, something that isn't very apparent for a lot of people, and can obviously present a lot of risk factors when change or transition does occur.
Yeah, no, thanks, Johnny. Great response. I think as well, that's the kind of stuff that you'd want to see implemented in schools, isn't it? We all do PE as kids, but there's nothing that we do to look after arguably the more important side of our health, which is our heads. And I know Scott's just put a little thing in the chat there. Hi, Scott. Good to see you, mate. Around working on emotional intelligence, and I fully agree. Alex, Chris has put his hand up, and I'm not familiar with Zoom enough to know what to do with that. So if you can let me know how we do something about that, that would be great, and we can come back to you later, Chris. Johnny, thanks for that. Absolutely amazing. Vikki, over to you.
Hi, just give me 1 second. I'm just going to do a short presentation for you.
Oh yeah, Rory, if you can now make Vikki co-host, we can get Vikki sharing that screen.
Hi, I'm hoping it's come up on the screen now. Can everyone see it?
I personally can't, but Rory, any inroads, mate?
I've made Vikki a co-host, so I don't know why the share screen feature isn't working.
So Vikki, at the bottom of your screen, there's like a little green arrow saying share screen. If you click that.
Yeah, I've shared my screen. It's all up on my side.
There we go. It's working now.
There we go. We're up.
Brilliant.
Good boy.
Yeah, all there ready. Jordan's conversation. Right, so basically, I'm Vikki Thomas. I'm the relationships manager at Seddon Construction. I'm one of the mental health first aiders and a Jordan's Conversation ambassador. We created Jordan's Conversation back in 2018, as sadly in 2017, one of our painter and decorators, Jordan Bibby, he sadly took his own life. So we worked with his family who agreed for us to dedicate this toolbox talk to him. We deliver this toolbox talk yearly. It goes to everybody in the business and to the supply chain. And recently we've delivered it to a couple of our frameworks that we're on, and the SIG groups, which has been received really, really well. So I'm just going to do a quick overview of what we cover in Jordan's Conversation. It's an interactive workshop. It can take between 30 minutes and an hour, depending on how active people in the group want to be. But we discuss what is mental health and mental health stigma. We go through some facts and figures around mental health, particularly in the construction industry. Identifying and dealing with stress, which leads on to the stress container, which we go into some detail, which is great. And then we have some slides on self-care and of different things. If you've got 5 minutes, 10 minutes, 30 minutes of daily self-care, which we all should do. Then we've got a big section on the Seddon Employee Assistance Programme, which is amazing. When I've delivered this to some of the other frameworks, the other construction companies have said they've all got something similar to this, which is really, really good to hear. We use Care First, there's online counselling available 24 hours a day. We can have face-to-face counselling up to 8 sessions a year. And it doesn't need to be mental health as well. It can be financial advice, legal advice. And they also offer a mental wellbeing app. The app's just on your phone and it just asks you daily how you're feeling. You can keep a track of your wellbeing. There's some breathing exercises on there and meditation. So it's a really, really good app. I have that myself on my phone. So yeah, that's great. And then we discuss external support and charities that we have in the construction industry. I'm presuming a lot of you will come across these, the Samaritans, Meet in Mind, etc. We have these across the board in the business, in the electric TVs with the screens, back of the toilet, on the notice boards on site. And if they are on the screen, they're obviously coming across maybe every minute to 2 minutes, depending on how much is on the board. So there's constantly information on hand for help for everybody at Seddon. Just on some key facts of what we've done over the last 2.5 years. We've delivered over 50 talks to 400 people. I think that figure's a lot more now. We're ready to update our Jordan's conversation, so that figure will be higher. In 2018, we signed the Time to Change pledge, and we've won 2 awards. We won the Most Inspiring Mental Health Initiative at the Inspire Awards, and we won the Mate in Mind Award for large organisations, and they're 2 awards that we're really, really proud of. I think they're amazing to have, and it just shows all the hard work has paid off. We're very active in the business with mental health. COVID, just some key things that we've done in the last 11 months. We've delivered Jordan's conversation remotely to staff. It's been a bit hit and miss with some of the sites. Just the interaction wise, I think you can get people to interact more when you're in a room with them, but obviously we've all had to change with the times. We post wellbeing posts weekly on our internal communications channel, usually self-care, some self-help guides for people living on their own or people with children and trying to work as well. Yesterday we distributed a talking toolkit, preventing work-related stress. That was actually done by the HSE. I had a look at it yesterday and it's really, really good. It's open wide for anyone to gain access to that. I can distribute it if anybody wants the link to it. We're also actively calling the site teams every 2 to 3 weeks to check on their well-being, to check that the teams are okay. We're getting some really good relationships built with this. I've had a couple of site managers who've opened up and needed some support just before Christmas, which was really good to see that obviously we are helping people. The support is there as well. As discussed, we've delivered Jordan's conversation to some framework social values SIGs. And then most recently, we're creating some support for staff who've been off work with COVID. There's some open forums and one-to-ones, and we're sort of buddying them up with other people who have had COVID and helping them back with a transition back into work. I think obviously if you've had COVID yourself, it's relatable, and you'd have more of an understanding of the effects of obviously transitioning back to work. So that's something recent which is doing really well. These are just my details that go on the boards for the sites that I'm an ambassador for. We will send this slide out to you all on the call as well. So if any of you want any more information on Jordan's conversation, we are looking at helping other people, doing some leadership courses of how to create your own toolbox talks. or any other information, I can actually send you over the full presentation, the current one that we've got. So my details are there. So quite happy to share those with you. We massively want to promote Jordan's conversation and the mental health within the construction industry. We know their figures they're really, really high. And that's me done. Thank you very much for listening.
Yeah, thanks, Vikki. It was great.
You're welcome.
Stop sharing your screen now. We'll go back to the main, just at the bottom.
Oh, yeah, there we go.
Yeah. Yeah, thanks for that, Vikki. I think a few people have put in the chat that they would like the stress link. I think Julie's asked for that. So I know you said you'd send out the slides, but also, the stress stuff that you mentioned, that'd be great.
Yeah, definitely.
If anyone's got any questions as well, I think we're coming back to you later, Chris, once Rory manages to unmute you later on. But any questions, please just throw them in the chat. Okay. Have a think of your questions and you can ask them later on. I'll now do my part. So we did talk about, I think it was 2 weeks ago with PL around COVID. And it was myth busting, really. It was talking about like COVID presentations. Some people don't think COVID exists. So we were just like, we've got to do something about this because it's just, there's so much disrespect for people who've actually died of this. And, I'm sure a lot of you guys on this call have been affected by it because it's so prevalent now. So we did that talk about 2 weeks ago. We're going to go over a couple of things from that talk, just a little bit about COVID and then also mental health presentations that I've seen as part of my medical career, and then also a bit about this startup that we're doing with LYFE. So let's get cracking. If I share my screen. Okay. I think it's here. Can everyone see this? Just give me a nod, Vikki, if you can see this, and everyone else will be able to. Yeah. Okay, cool. So a bit about myth busting, like Alex, who's part of PL, and Rory both told me a couple of weeks back after the feedback of the first session that some people didn't even think that I was a real doctor and that I'm being paid by Boris as a part of this all big cover-up story that, the NHS is rammed by, like, I don't even know, but like they didn't think I was a real doctor. So here we go. Here's some pictures of me at work, bottom right being a bit of a clown, but, big picture on the left, that's when we were sending out COVID samples. And, we do take all precautions that we can. We actually have PPE now, which is nice. But you can see there on that bottle, big biohazard. All of our samples like double bagged and they go in these steel containers to make sure there's no cross contamination. But yeah, I promise I am a doctor. I'm not some cowboy. Okay, so this is, so some people, you see in the news all the time around PCR swabs and lateral flow tests, and we've got loop testing coming in. People are like, they're so obsessed with these tests, and it's like, in medicine we don't just go off a test. Okay, like if you get your bloods done at your GP, we're not purely going off your blood results. We never act on just a blood result. We always look at the clinical picture as well. So that includes imaging. Here's an x-ray. So we've got imaging, we've got the clinical picture, we have blood results, we look at your past medical history, we look at your genetics, family history, your social history. It's not like, oh, the stats of this test is 2% false negative, and we don't do that. We look at the whole picture. So here's a normal chest x-ray. That's just to reassure you that we aren't purely going off PCR tests. So here's a normal chest x-ray. So black is air. So anything which is black is less dense, and the white is more dense things. So if I can hide this. Okay. So you can, if you follow my mouse, my mouse is here. If you follow this, you can see here, we've got nice angular parts of the lung. This is called your costophrenic angle. And we follow this around. That's your diaphragm all the way around. And then this is obviously your right lung. So this is right side. This is left side. You see the big L here for left side. And then this is the other part of your diaphragm and the other nice sharp costophrenic angle. That's what we like to see. This is a nice big, you see how much air space there is in the lungs here. That's beautiful. That's what we want to see. This white mass here is your heart. So you can see it is slightly deviated to the left. That's normal, but it's more central than people think. This little bit of blackness here is actually an air bubble in your stomach, in the top of the stomach. Some people think, oh, I've perforated my bowel and I've got air beneath my diaphragm, but it's not. That's your stomach. That is normal. A bit of landmarks for you. This here is your collarbone, your right collarbone. This is your left collarbone. And these ribs that you can see here more prominently, that's the back of your rib, because the x-ray is actually fired from the back to the front. So anything on the back of your body, you actually see more pronounced. So that's the back of your rib. If we follow that round here, all the way around, then there's the front of your body there coming around the front. So that's a normal chest x-ray. You can see here, this coming down here is the trachea, your windpipe, and it's coming into the right hand lung here, and all of these little tubes are the air tubes which go to the edges of your lungs, so you can get air into every aspect of that lung. Okay, that's what we like to see. That's a lovely x-ray. Now, hang on, this is a pneumonia. Now you can see this doesn't look anywhere near as open. We've still got those nice angles here, the costophrenic angles, they're still quite nice. But if you have a look here, this area is patchy. It's what we call right-sided middle lobe consolidation. So it's gone white. The reason why it's gone white is because the area is denser. There's not as much air in that area. So it's got like fluid, it's got mucus, it's got basically crap in there that the body's produced trying to fight off this pneumonia. So pneumonia is a bacterial infection, and you can see that that's kind of isolated to one area, and this is typical of a pneumonia. So that's what we call one-sided or unilateral presentation. If we go on to COVID now, you're going to see how very different it is. So remember this, it's this lung looks okay. This pneumonia is one-sided. This is COVID. Now look, compare that to the old chest x-ray where it was big, black, open spaces. It's just shocking, isn't it? Like, you've got no lung space at all to get air diffusion happening and getting oxygen into the bloods. Like the costophrenic angles here, you can barely see. That's called blunting of your costophrenic angles. You've got bilateral, so both sides, consolidation, white fluffiness throughout. It's really poor. And then if you go off that alone, you think, oh Christ, that's not great. If you add on the fact then that they might be overweight, they might have diabetes, they might have had a previous pneumonia in the past, you know, the picture already is not looking good. You can see here, this is an ECG lead here coming in. So we're actually monitoring this fella's heart at the same time. You can see them there. But yeah, you can also see some fatty tissue at the top here. So you start thinking perhaps this is a slightly overweight guy as well. In fact, it definitely will be. If you have a look at this here, erect, don't get childish on me, but AP means anterior posterior. So this one's actually, this x-ray is actually fired from the front. Typically they're PA, like posterior anterior, so they're fired from the back. But because this guy's, I'm guessing, so overweight, they haven't managed to move him to a position where they can fire it from the back. So yeah, this will be an overweight gentleman or lady. So this is classical COVID. So we have, remember said before about we do correlate with tests. We do correlate with PCRs and lateral flows, typically PCRs because the highest specificity. But, oh, if I go back, sorry, 1 second. That is called classical COVID. So you'll see this code in medical notes, CVCX1. If it's normal, if you have a normal chest x-ray like we had previously, we'd then have to look further into the clinical picture to see if it is actually COVID. Indeterminate means we're not sure. Non-COVID means it's something else like a pneumonia, where you'll get that classic kind of unilateral, well demarcated space in the right middle lobe. So you can see there how COVID does look very, very different to other things. And we're not just going off swabs, okay? So please don't watch like PTs on Instagram harping on about swabs. It does me head in. Like we are taking into account full clinical pictures here, and a lot of effort goes into correctly diagnosing these guys. Doesn't matter about your 28-day swab result. Okay, a little bit around what we actually do around COVID. So Unfortunately, there's not tons that we can do. The mainstay treatment sits around getting oxygen into the lungs. So it's kind of like a stepwise approach. So we start down here with nasal cannula. That's what it stands for. We put them on nasal cannula, which are the little oxygen tubes that go into your nose. And then if they're still desaturating, so you put the little thing on your finger, and if you're sat to drop them beneath, ideally we want them above 92. In healthy people, normally we aim above 94, but with COVID, we've reduced it slightly just because we settle for 92. If we drop them below that, we want to put them on some specs, and we start here. If they're desaturating still, we'll step up to a Venturi. I absolutely love a Venturi. The oxygen control you can get on these is fantastic. So they're actually these things here. So you can see there it says 24% or 2 liters. The stuff that you breathe in air ranges between 18 to 21. So you think that's only a small increase in oxygen, which it is, but it means you get really specific oxygen control. So if they're desaturating on this, I can increase them to 35%, and I know exactly what percent of oxygen that they're getting. We don't actually stock 31s in England. This is an American picture, but you go 24, 28, 35, 40, and then you go to 60. So you get really, really good tight control on the Venturis. They're absolutely fantastic. And we can step people up and down these Venturis as and when they need it. Next stage after that, we go for a non-rebreather. And with these, you're getting around 85% of inspired oxygen. We don't use high flow nasal cannula really. They're not fantastic. They don't get a very good, if people are breathing in and out the mouth, for example, we want to make sure that it's actually, we're getting tighter control in that. So we step up to masks because they're tighter controlled. Then you go on to CPAP. So this gentleman here, young guy, he's on CPAP. It's very, very uncomfortable. The machines that they're linked up to are huge. It feels like, if you imagine you're going 80 on the motorway and you stick your head out the window, that's what it's going to be feeling like. That's the amount of pressure that we're forcing through these pipes. And that's why he's got like seat belts strapped around his head, because it is not pleasant at all. But the reason we have to do that is because if you look at this picture, we have to force air to try and open up these. You have like little sacs within the lungs which have collapsed, and that's why they're so sticky and full of gunk. Basically, we have to force air in at massively high pressure to try and force those sacs to remain open so we can get oxygen into the blood. So yeah, that poor fella's on CPAP, not very comfortable at all. When we say we're struggling for beds, we are struggling for CPAP, these beds, and intubated beds. We aren't struggling for this. So you see some clowns on the news going around taking pictures of Aussies. They're taking pictures of non-COVID wards. We have enough beds for this kind of stuff. We don't have enough for CPAP and intubation. All of our beds at the moment, even though rates are still going down, are still completely full. And we have to put strong escalation plans in place and ceilings of care to make sure that the most appropriate people go onto CPAP. And then failing CPAP, we then unfortunately have to intubate. And that's, of course, where we don't want to get to. 50% of people who are intubated do end up dying. So yeah, not nice at all. But yeah, it's part of the disease. So pharmacologically, what can we do? What medications can we give? These top two are the main two. So dexamethasone, I'm sure you've seen this in the news. This came out in early studies that it was quite effective against COVID. Typically severe disease, though, it's a steroid treatment. We give it for 10 days. We start off at IV. If you go to A&E with COVID now, we give it straight through the veins. We try and step you down to oral tablets when we can. But obviously, if your disease is quite severe, we have to keep you on those IVs just to make sure that it's getting around your body effectively. Enoxaparin, I'm sure you've seen this in the news as well, and it is actually true. It increases your risk of having deep vein thrombosis or pulmonary embolisms. They're both respectively the clots in your legs or clots in your lungs. And enoxaparin I'm sure you've heard of warfarin. It's similar to warfarin. It's an anticoagulant, but it's far better. We get much tighter control on this, and we can dose adjust really, really quickly. And enoxaparin is fantastic. So we give all of our patients treatment dose enoxaparin. So there's a difference there between your prophylactic dose. But yeah, these are the mainstay. We ensure that all of our COVID patients are on this. These other three, there are trials to try them, with also aspirin as well, but remdesivir is an antiviral treatment. So COVID's a virus, your pneumonia are bacterias. The remdesivir is an antiviral treatment, and some studies have showed that it's worked, some shows that it hasn't. If we can actually optimize our oxygen treatment and this with appropriate standards of care, we find that is better well done than playing around with these other drugs. I always struggle to say this one, the tocilizumab, that is, if you have a look at the end of the name, MAB, monoclonal antibody. So this is like a new kind of treatment which effectively reduces inflammation. So, we talked about all of the gunk in the lungs. That's what this is aiming to do, trying to reduce that. The dexamethasone does that to some description too, but this was something else that we trialed out, and the data worked in some patients and not in others. So we do save these for really, really high risk. But if you go to hospital, I doubt that you'd see yourself on these. It's only if we're really, really poorly. The azithromycin, that is if you're getting a pneumonia on top of your COVID, which is a big risk. You can have a COVID alongside the pneumonia, and they're the pictures which typically are going to be killing people. It's not nice. When we have a look at blood results, you see how people react differently. We look at a full breakdown of your full blood counts, and whether you've got a pneumonia or a COVID, slightly different things happen. But if it's a mixed picture, especially if we look at swab results and we look at the x-rays, we can kind of tell whether it's a COVID pneumonia as well. So that's kind of what we do pharmacologically. The other things that we can do is positional therapy of the patient. So we do something called proning. So we lie the patients on the front, and it opens up the back of the airway just to release the weight pressure on the chest. Early mobilization, early discharge to get them moving is also key. The worst thing that we can do is leave somebody in bed all day. If you imagine you slept in bed for 2 days straight, you'd be feeling fairly poorly by the end of that. So please, what can you actually do is get your vaccine. We would not be rolling out the vaccines if they weren't safe. Of course, it's hard to find data on every single tiny aspect of vaccines, but this particular vaccine is a relatively new thing, the Oxford one anyway. It's not as new as you might think. We actually Oxford University started the research on this around 6 years ago when they were building the building blocks of the virus. In fact, if I just, I'll stop sharing now. Okay, so what we did was we took, with the vaccine, we took like a building block. So we took an adenovirus from a chimpanzee. So we adenovirus is what causes the common cold, and we took that from a chimpanzee and stripped it of all its DNA or RNA. We stripped that all out, and then what we did was, from that, we got the coronavirus and brought that in, and then we looked at what made it a coronavirus. The reason why it's called coronavirus is because of the spike proteins on the outside of that virus, because it looks like a crown. Corona in Latin is crown. So that's how it's infecting people. And you'll see that the mutation, which is kind of spreading, that spike, how it infects, has changed somewhat. But we still think the vaccines remain effective. Now, the good thing about this Oxford vaccine, so we've taken that spike and we've put it in the adenovirus, and the adenovirus has then exhibited that on the outside, and that's how we've created this vaccine. So then your body produces an antibody to match that perfectly, and that's how we fight that infection. Now, that building block that we're talking about, the beautiful thing about this vaccine, that building block, if you imagine it like the foundations of a house, we've already built the foundations and we built the walls and the roof. And then that spike protein that we take from the coronavirus and put into the adenovirus, that's that's like decorating the house on the inside. So the building block's done. All the hard work's done. If that spike changes, if the virus mutates in whatever way, we've still tested that building block, which we inject. It can't infect you properly. It's like, it can't replicate because it's like a defunct thing. It'd be like a cat breeding with a snow leopard or something. It produced like this defunct thing, like it can't reproduce. But yeah, that's the beautiful thing about the Oxford vaccine, is that the building block is built, and however the thing mutates, we just redecorate the inside of that house and we got a new vaccine, and it's already tested. And this work started around 6 years ago. They were trying to build this foundation. So it's actually amazing what they've managed to do here. Happy to answer any questions around COVID and vaccines, and yeah, honestly, whatever. Like if you have any questions, just throw it in the chat, because I know loads of people were asking quite specific things last time around vaccine passports and where we think it's moving to. But yeah, if you want to have a think and just ask away. Okay, mental health stuff. Let's get back on topic. So Johnnie and Vikki provided a great overview there of the impact that they're making in society, and you know, it's fantastic work. I love to see it. And, you know, we touched on some great things around how we need to start educating people about how they can proactively look after their health. And this is exactly what we're trying to do in GP land, and also what I'm trying to do with my little startup, LYFE. Typically what we see is, Johnnie raised a good point around change in life, and it is difficult for people to engage with change in their life. And the best way to kind of conceptualize this is order and chaos. So the chaos is like the new crap that comes your way, and you can prepare yourself enough for it, but you still don't know what's going to come your way. The order are the things that we can do to actually to build resilience. Hang on, what's that there? Yeah, okay, fair enough. So thanks, Ian, for that. The order is the things that we can do. We have to take personal responsibility for creating order in our lives. It's not somebody else's responsibility. And I think, Ian, based on your point there, this is something which is kind of, it's been let go. It's slipped by the wayside somehow. People need to take individual responsibility for their own mental and physical health. We do have lots of support networks, and of course we want to help people, but fundamentally it is the individual's responsibility to look after their mental and physical well-being. If they don't do that, then we are here to help. But that is a big point that I want to press, is that with the right tools and the right education, you can look after yourself appropriately if you know what you're doing. And that's where I think people struggle to build resilience, because we are not taught what to do. Look, society looks very different. I'm only a young guy and I don't know what it was like in the past. But I know from looking at the developments, especially the technological developments that we've had in the 21st century, that the world is such a different place. We're social animals. We have to engage with one another. Lockdown hasn't helped. We're socially isolated. Social media is crap for your head. And everyone's aspiring for this like ultra high career kind of outlook on life, and it is bad for their heads. You need to be physically active when we're stuck inside and we can't do it as much. That's also bad for your heads. But what we see a lot in GP and what we see a lot of in hospital is people who, they know that they don't want to feel how they feel. They know that they're struggling. They're like, I don't know quite what it is, but I don't feel right. I feel down, like day to day, maybe 3 or 4 days out of the 7 in a week. I feel a bit rubbish, but I don't know what to do about it. So one of the best first approaches that you can do, or that you can take, is around creating that order in your life. So you've got the order and you've got the chaos. The chaos are things outside of your control. You can kind of prepare for it, but not always. You don't know what's going to come your way, and that comes on to a point later, which I'll come on to, which is around life is very difficult. But let's focus on the order, what we can actually focus on. Create a schedule. create a routine. This is absolutely fundamental for your health. Okay. One thing that I do with all of my patients is go to grab yourself a piece of paper right now. And if you want to do this right now, we can go through it. Grab yourself a bit of paper and write this down. So we focus on a topic called the outside in approach. Now, what happens is we look for something internal to actually do something. We look for like a feeling, or we look for something to energize us to go and do X, to do Y, and it doesn't happen because you're looking for it. It doesn't happen. So what we need to do is we need to do an outside in approach. And this is psychology 101. This is what we do with absolutely everyone. So I say to them, right, think of 3 things that you can do in day 1 that will schedule into your life. So we'll create a schedule. What are the 3 things that we can build into your day right now that you can feasibly do the next day to start creating a bit of order? So for example, it might be that at 8:30 in the morning, I set my alarm, I open the curtains and I make the bed. That's a good step 1. It gets you up. You're out of bed and you're probably going to go make breakfast after that. So there's 1. It might be on your lunch break at work. If you're working from home, we'll go for a 15-minute walk. That's feasible. That's good. That gets you up out of your chair, bit of exercise. You've got some fresh air. You might have gone into nature, which is again good for your health. And part 3 might be that, I don't know, I feed my chickens. That was one of the ones with this patient. All of his chickens were dropping like flies because he just couldn't be bothered feeding them. Poor chickens. But yeah, it's going to be very bespoke to you. So just write down 3 things that you can do the next day that you think you can feasibly do and will make your life better. So simple. And assign it to a time. You assign it to a time. That's the outside in approach. You're not looking for something internal to go and do that thing. It's externally set. You just do it. The time comes and it's done. We do that for a whole week. We do those 3 things for a week. And in the next week, we set 3 more. And you can see if you do that for 2 months, 3 months, you have a very, very proactive day, which is good for your health because you're only going to schedule things into your day that you want to actually do. So that's kind of like, I'd really encourage all you guys to go and do that because it makes a massive, massive difference to people's lives. And they're taking their own responsibility to go and do those things. And it's so simple. But what we find is in today's society, and this is why I've got so much respect for people like Johnnie and Vikki, is that when somebody's struggling, they actually don't know where to go. And the first point of call is always the GP. So they'll call the GP and say, I'm struggling. But 10-minute consultations due to the demands of the NHS is like, I haven't got time to do this work with you. Unfortunately, they haven't got the time to do that work with the patient. So it's like, here's some antidepressants, here's some sertraline for you. And it's like, well, this isn't going to help because the underpinning problem remains the same. They're not getting out of bed. They're not eating. They're not drinking. They're not walking. They're not exercising. What is an antidepressant tablet going to do? It's ridiculous. Anyway, I think I've ranted on enough there. That's a really simple thing that you can do. The outside in approach. You can go away, Google it. We do it with almost all of our patients, and I can't recommend it enough. It's absolutely fantastic. Final point from me would be that life is difficult. I've had some relatively crap times over the past 12 to 18 months, trying to balance my own life. And, you know, it is difficult taking advice from other people. It just is like, it's easy to say, oh yeah, I will do this, but actually implementing it is difficult. And I, you know, every week I'll reflect and make a few notes and try and piece together exactly what's gone on and how to stay stable. But it's not always going to be the case, and you will fluctuate. Your health, your mental health will go up and down, but it's accepting that kind of journey as well and not overly assessing how you're doing, because you can become obsessive with it. I'm sure you've seen like people on MyFitnessPal who count like micro calories. It's like, oh, I've had a gummy bear, so I can't eat for the next month. You know, we just need to be reasonable and see the bigger picture. You are going to fluctuate and go up and down. But yeah, being accepting with that and realizing that it is a long journey, it's a marathon, and at times it's going to be very difficult, but with the right support and the right tools, We can get through it and we can enjoy it. And then you'll appreciate the good times. All right, that's probably enough from me. If there's any questions, guys, just throw it in the chat, or we can unmute. Yeah, go and get a drink, have a think of it, but we'll sit around for the next couple of minutes to answer any questions that you've got. I know that you had one. Who put the hand up before? Somebody put the hand up before. Chris put his hand up before. So any questions, fire away.
Yep, I'm coming through now.
Yep, go ahead, Chris.
Yeah, I've specialised for umpteen years on taking stress away from people, and I met up with you at probably well over 12 months ago now, and I think you were in or you were setting a place up in the Albert Dock. Is that correct?
Yeah.
And you were too busy. You were running around then, busy as hell. So we never met up. And then we got this pandemic, so I've not been in touch with you. So really speaking, it's if you, and this is from everyone here, you three of you, Vikki and Johnnie, if you can give me your phone numbers, right, I mean, I'll contact you again. And what I can do is, especially with you, Ed, because you're right in the thick of it completely, actually physically doing things, I can show you some techniques that take away stress from people and mental health problems, and they're rapid and they work. If you remember, it was stuff I was talking about was Qigong, which is traditional Chinese medicine, which is energy therapy. And I know it might sound a bit peculiar to people as I'm talking now, but it actually works. Takes away major problems that people have had sometimes for years.
Yeah, no, sounds good, Chris. We'll share our phone numbers after this. Thank you for that.
Yeah, definitely.
If I can help at all, I will do.
Thanks, Chris.
Yeah, cheers. Is there anyone else? Anything that you want? Anything for Johnnie? Anything for Vikki?
I'll maybe just follow on, because I think one of the questions there was around how can people build resilience, and you've given a great overview there. Just maybe a few additional points to kind of spark some questions or just some comments. Is people don't become well unless, in this majority of times, at least anyway, overnight. There's an accumulation, there's a build-up of, let's say, from a mental health point of view. Don't get me wrong, there are cases where trauma is experienced and people can kind of become quite unwell in a shorter space of time. But in the majority of cases, people become unwell over a period of time. And that said, the reverse is true. People become well and become more stable, or come out of what might be a crisis or a difficult moment kind of over time and step by step, day by day. And if you we utilize analogies to help people kind of conceptualize some of these kind of bigger things, that what is mental health, how do I navigate difficult times, what is resilience. Some of these can be a little bit in the ether sometimes, and kind of utilizing everyday examples can be a little bit more helpful. So we utilize the analogy of a bank account. Our mental health, we have a mental health bank account, and you don't become a millionaire overnight, working a 9-to-5 regular job. You slowly accumulate, and you save, and you put aside, and you invest in something to a point, over decades or over a prolonged period of time, where it then accumulates into a lump sum. Same is no different when it comes to, poor mental health. People don't necessarily become into a state of crisis overnight. It's normally accumulation of, not doing the things that they know that keep them well. So it's those daily practices, as Ed mentioned there, around knowing what works for you, and making them as actionable and tangible and as easy as possible, and implementing them into your day to make those small deposits, little and often, as opposed to a complete overhaul. I've got to suddenly do this 20-day regime and new year, new me, and those things can work, don't get me wrong, but I often find when it comes to sustainability and long-term behavior change and making that an integral part of people's, life and lifestyle in the long term. Is that little and often, that little deposit, the weekly, monthly, daily contribution into your mental health and well-being bank account, as it were, that can really make a difference. And one of the skills that I think is one that we all may be aware of, but again, can be hard to kind of draw down, is the art, is the skill, is the practice of reflection. So if you think about it, we all experience, we are experiential beings. We have an experience with life and its interactions, both the inside and the outside, the internal and the external, every single moment of every single day. But what is it that turns our experience of life into insight? Insight is really what we're trying to get to, isn't it? Because we're all trying to utilize the experiences that we've had, good, bad, and shades of grey in between, to then be more informed, better equipped, more empowered to then do life better. But what is it that turns our experience, which again could be all shades of grey, into an asset, into insight? And that middle bit between experience and insight is reflection. Because ultimately, if I just go from experience to experience to experience and not necessarily try and draw down what was the good, the bad, how I could have done things better, then we never kind of learn, we never process, we never accumulate those tools that kind of inform us for future experience. So reflection is a massive part of becoming more self-aware. And again, rather than coming up into the same experiences and having the same outcomes, we can be more informed by way of our past experience and learning and analysing that and reflecting on that, to be more empowered and more equipped to then better deal with the challenges that we're all going to face. Let's be honest, no one goes through life without any peaks or troughs. So reflection as an art form, as I say, a skill, is something that we can all do. And as Ed mentioned, a lot of the stuff we kind of get consumed with is, I've got to do, the marathon, I've got to do, 20 minutes of this and half an hour of this. And before you know it, you can become a little bit overwhelmed by it all. But what I would say is, as I mentioned, those small, tangible, practical tools that you can implement on a daily basis, accumulated over time, and working out through reflection and being analytical, what works best for you. You'll get to your tool guide, your kit bag, and that's an individualized approach that everyone can have at their disposal and take ownership of it and shape it over time. That can really be an asset to them in their own health and well-being journey. So yeah, I just wanted to add that. Sorry.
Yeah, Johnny, that's great. Thank you for that. And reflection is so key. Fantastic insights from you there, Johnny. That reflection as well doesn't necessarily have to be you sat by yourself writing stuff down. You can share the experience with other people. So actually, if you work in a team, one of the things that we look at is asking how people are. I know that's a really weird question to ask, but like, how do you feel today? And then they might not actually give too much up, because it depends on the rapport you've got with the person. But if they don't give too much away, just like, are you sure you feel all right? You can ask again. Don't be afraid to ask twice. And then you might have a discussion and reflect together and impart personal experiences that you've both had. So you have a joint reflection, which again is also good. It doesn't just have to be, I sit down on a Sunday evening and write stuff in a book. It can also be with another person. But no, Johnny, that's great. Also, if you don't want to reflect just now, say if it is a traumatic event, it's normal to have a period of grief. It's normal to have a period of time where you don't necessarily want to re-engage with that memory, because you might actually just need to shut it out for a little while to reduce that cortisol response. But yes, reflection is very, very key. So thanks for that, Johnny. Hazel's just put something in the chat. Yeah, fully agree. That's great. If there's anything else, guys, we'll sign out now in a second. But if anyone's got any final thoughts, just quickly whack them in. If there's not, we'll tie it up. But no, thanks, John. I'm glad you enjoyed it, and thanks, Hazel, and everyone for the comments. Again, I'd just like to thank Constructing Excellence Liverpool and PL for organising this event. And thanks to our speakers, Johnnie and Vikki, for coming on. And of course, to Alex and Rory for sorting out. So thanks, everyone. Enjoy lockdown, get your vaccines, and I'll see you guys soon. Bye-bye.
Bye.
Bye.